Welcome to our final spring webinar for today for the Annie Research Work Group. We are very excited to welcome back one of our own from this work group, Dr. Jessica Castner. She is from her own Castner Incorporated that she runs as president, and also editor-in-chief for the Journal of Emergency Nursing. But we think of her as one of our own because she is the past chair for this group, I think 3 chairs ago. So she's very linked to this. She is really the individual who helped us think about bringing in nurse scientists and recording and archiving their work. So we're very grateful for her because now we have an archive of 20 plus nurse researchers in environmental health, and that's really her brainchild. So we're very pleased to welcome her today back to talk to a group that's very much she's part of. So Dr. Castner, please take it away.
Well, thank you so much for that introduction. And, I know that these recordings are sometimes used for guest lectures or, go on and are watched after the fact. But I do see for those of you who have joined, make this as interactive as possible. This was originally developed as a very informal talk to people in master's and PhD programs or junior nurse scientists grappling with asking biomedical and policy questions related to environmental health nursing. So this just lays out in a very informal way, in a way thinking out loud at some points in my own research program. So as things interest you or touch on what you're studying or touch on what you're working on, please engage in the conversation. I'd be happy to answer that. So my disclosures were really on my first slide, and that I'm principal and owner of Castner Incorporated, but these are some of the generous funders and supporters of the research work that my team has completed, of which I am so grateful. So my interest in environmental health goes back to, my time as a certified nursing assistant and bachelor's degree. My first job as a registered professional nurse was in home health in Milwaukee, Wisconsin. And my assignments typically were in the three poorest zip codes or most low income zip codes there. And boy, do you see environmental health of indoor housing quality upfront as a home health nurse, as well as some of the sequela. But I'm a board certified emergency nurse and an asthma educator. So the majority of my clinical career has been in the emergency department setting. But most of my work is really at this intersection, which now is telehealth, right? Trying to prevent that emergency or follow up in the care between the care after the emergency. And so it's really beautiful to meld these specialties and experiences of what the home environment is like and how to prevent those health emergencies. As an emergency nurse, we get a lot of training in acute poisonings and saw a lot of emergency toxicology. And so the outgrowth of the health effects of lower levels of toxins was just a natural progression for me personally. And this talk was originally developed for the Rockefeller Heilbronn Nurse Scholars Program. And it was such an incredible program based on a family whose appreciation for home health nursing really created the generosity and the donation for that center. And that family is tremendously involved in climate change work. So, all points really intersected in these really important ways at different points, in my career and the folks that support this type of work. So let's talk a little bit about what is an endotype. So it's really a word for the underlying pathophysiologic mechanism of a disease. And Much of my work that's been funded has been asthma because it is really a disease of the environment in many ways compared to other diseases that exacerbate and have an emergency. But we do know that asthma is not just one disease, it's heterogeneous. There are various phenotypes or expressions of the disease depending on your traditional diagnostics, depending on molecular classifications. The most recent guidelines and the updates that came out in asthma care from NHLBI acknowledge that asthma is heterogeneous and there's different phenotypes, but the guidelines aren't quite there yet to do these precision interventions based on the different phenotypes. So we know that science is coming. We know that we need to continue to develop that science to really look at how do we make the nursing care and the medical care of asthma very precise depending on these different types of asthma. A lot of the research that currently exists focuses on childhood onset asthma, which is often really closely associated with viral infections as well as allergens. There is a real gap in many ways as to adult onset asthma, which is often occupational related. It often tends to be more environmental. It's often tied more closely to obesity and other comorbidities. So just the structure of this talk is not to really go through any one particular research project, but to do a high level overview with just a few details and a few published papers. So talk a little bit about philosophy and outline that thinking when trying to develop the research questions, talk about some of the frameworks that's been relevant to collaborations in this group for environmental health, and I hope to create additional collaborations here. And one of those frameworks is the NIEHS TRF, and we'll use that to talk about precision intervention development. Because when we're talking about nursing science, we're often talking about, well, what we've identified the problem, what do we do about it? What is the nursing intervention? And how do we develop those precise interventions based on environmental exposures? So first, a little philosophy and way of thinking and really digging into how do we know what we know and what are those gaps? And so I like this slide as a bit of a, what was then and what was now. And how do we justify belief from opinion and what facts do we know? And in this, I really love the value of nursing science and how important symptom science is and how important what nursing is so special in the temporal. We tend to look at the critical patient minute to minute or hour to hour. We really do a lot of the surveillance and monitoring at that really tight temporal level compared to the other health disciplines. But this is one way to really turn insider and outsider thinking backwards is to consider what we used to assume as a discipline to be true and how that's changed and what kinds of questions and sometimes how unusual it may have been to answer some of those questions. If you as a nurse scientist ever doubt that you belong in the biomedical space or in the policy space, or if you start to hear colleagues or your own thinking saying, well, that's just something that's too medical, please never forget that the CBC, the complete blood count, which is the basis of so many diagnostics and the direction of care, was developed by an interdisciplinary professional. Culture was an engineer who looked at this problem from that interdisciplinary perspective. And I love that because that's central to what we do. So sometimes it takes that outsider thinking or that outside the box thinking to create the revolution and the foundation of the next generation of diagnostics, prognostics, and the way that we care about patients. So this is just, it used to be that they'd find a circulating lymphocyte in the 60s and they're like, what's this, right? Well, we now know that this is the central focus of immunology. If we didn't have memory cells, we wouldn't be able to respond to infection again in the future. In the 1970s and even in the beginning of my training, you heard this term junk DNA, this DNA that just seems meaningless. It seems like garbage. Well, we now know this has key regulatory functions of non-coding DNA. Again, at the beginning of my training, we thought of the lung as sterile. We now know that the microbiome is crucial in regulation and disease. So, then I go through that thinking, well, what do we assume today in practice that could really be the breakthrough of the future? And a few areas that I've been focusing my literature review and thinking on are fungal colonization versus infection as a local opportunistic disease. So if I think about my patients who used to have end-stage AIDS, or I think about the patients that we're reading about now or that you may have cared for with severe COVID, the idea of fungal infections as opportunistic is really central to our thinking, and we don't tend to think about it otherwise. And yet, there's some beginning evidence that many people are colonized with fungus in the lungs. Maybe they've had no response yet, it's just sort of hanging there. And we know that this is possible and it may be part of the microbiome, but we don't treat it like it might actually be the key to endotypes and phenotypes. And I'll circle back to that a bit later. So again, what we knew yesterday may not be the hallmark to defining some novel biomedical discoveries today. The other is IL-17 cytokines can be largely ignored. Often in studies, when I look at it in my literature reviews, I am fascinated by this little family of cytokines. It comes up over and over again in these adult onset phenotypes that interest me. But when I look in research, it's often, well, there were a few that were even above detectable limits, and compared to our other cytokines like our IL-6s or IL-12s, it just didn't seem worthy of analyzing, and so it got excluded from some of these key studies. So it was measured and then excluded. And to me, I've gone back to some of these, and if you have data sets, I'm very interested, and said, well, what if we just treat this as a binary variable, put it in, and anyone above detectable limits, sure enough, they often cluster as a unique phenotype. So there's just what used to be garbage or what used to be junk DNA or what used to be a cytokine that wasn't worth the cost because you could hardly detect it. Yet in those few patients where you could detect it, it may have been the key to some new knowledge. So that's just kind of keep questioning, keep digging, keep thinking about where this is going. So to switch from that epistemology and philosophy into a theory, this is the translational research framework from NIEHS. Luz was a co-author on a paper that we'll talk about here in developing the next research project or developing a next research idea in nursing science. Just very briefly, you have in the inner ring, you have fundamental questions, then application and synthesis, implementation and adjustment, practice and impact. And it's a nice way to map out a project or to think about where one fits in the continuum or where one's trajectory bridges along the way. So what you see here is I put my research trajectory in a lot of our team projects into these different rings and nodes to look at the growth of the translation and how it really heads into policy and into impact. Again, the citation is here, and I know Azita and Luz are both very active in Annie, and happy to sort of help you walk through crafting your own career cartography or your project cartography with some of this. Here, this looks briefly at, we know that about 8% of the older adult population in the USA and Canada has asthma. We know about 10% of the overall population has asthma. We know that the clinical care, if we're talking about nursing interventions and precision interventions for those with atopic or allergic endotype, are pretty well studied and well developed. But there is a gap in the science about these other endotypes, what other environmental pollutants or chemical triggers cause different types of phenotypes or chemical sensitive phenotypes. This actually includes nurses ourselves as direct healthcare workers at high risk for work-related asthma, especially for those of us who have a history of working with latex or that powder that used to come from the latex gloves, and cleaning agents, harsh cleaning agents in the healthcare environment. So another theory here is the symptom science model with environmental health. Again, a collaboration of this group to try to find those common threads as to what was foundational to inform our work. Complex symptoms at the top of this really resonates as an emergency nurse, because when someone comes into triage or when they first come in, you don't have the diagnosis yet. You're in this diagnostic uncertainty, and you do need to sort out if this comes from an environmental exposure or if this is from a different endotype. And so really briefly here on the top, you have the complex symptoms that the patients may present with or have an asthma exacerbation with, or other complex symptoms that tend to give meaning to what's happening underneath. Is there an underlying biology that creates these symptom clusters? Then there's the phenotype, which is all of the observable characteristics. So if I've got a patient coming in with wheeze, cough, phlegm, and difficulty with their activity because they're so short of breath, I'm going to ask about the environmental exposures that may have exacerbated it. Often for patients, I would see it may have been they knew they were allergic to cats, but they visited, a friend's house and the cat was there, or perhaps a chemical exposure at work. So your phenotype characteristics, it's it's your lung function, it's your blood pressure, it's all of those things, those data points we gather that we can observe, as well as their medical history and their surgical history. And then biomarker discovery is the component I want to talk to today with these IL-17s that really interest me, but there's certainly all kinds of biomarkers that impact those biology of symptoms, that can give us the objective sense as to the cluster that patient is telling us subjectively. And then last, we have the interventions. We want to develop novel interventions or look at new ways we can care for patients, help them self-manage, and so on. So we'll touch on that a bit here in this talk as well. So I'm going to go back to the NIEHS Translational Research Framework, and again, sort of focus this on some of the precision interventions for asthma. And here are just some fundamental questions in brief. So we know on the NHANES, the population level survey, that while not a lot of the USA population is diagnosed with an autoinflammatory or autoimmune disorder, a substantial and growing amount has detectable autoantibodies on their blood test. So if we think about the fibromyalgias and we think about the chronic fatigue syndromes, a lot of people are walking around with this self-attacking antibody that have no autoimmune diagnosis or autoinflammatory diagnosis. So that's a key question for me, looking at those complex symptoms that don't yet have a solid phenotype that makes sense yet. So, as a nurse, that really has fascinated me. In our work down here, you can see the title, again, collaborating with Luz on the older adult cohort with asthma in Louisville. We did find that if we looked at autoinflammatory comorbidities with asthma, it was substantial, depending on how we created the denominator, whether it was people we had all the information on or people we had most of the information on. We're talking between 1/3, 30 to 40% of all of these older adults had some type of autoinflammatory diagnosed comorbidity. This is huge. And what does this mean for the progression of the disease? So again, that intervention development that this lends the opportunity to is, should all adults with asthma have an autoantibody autoinflammatory biomarker screen? If 16% of the USA population is already walking around with it, and we're starting to notice it's common in older adults with asthma, is this amenable to screening and then to make the intervention precise to this particular phenotype, this comorbidity? Another that's come up consistently in my work is mold and moisture in the environment. So 11 to 13% of this cohort had detectable biomarkers, IgE, of a sensitivity to mold, so Alternaria or Aspergillus, right? So we don't know how many are colonized and walk around without the immune system creating memory to it or an allergy to it. But we do know that 10 to 13% are walking around with the sensitivity. But there really hasn't been precision yet as to very specific mold-based comorbidity phenotype and that particular allergy. So a lot of opportunities to start to look at making more precise interventions that way and reducing mold and moisture in the home environment. Again, in my home health work, in some folks with poverty or some folks who rented, mold and moisture is a huge issue in renters' rights, in safe housing, in old housing. And so, we know on both ends of that nursing coin, both what's happening in the body and what's happening in the home environment with disparities. This is really an opportunity to ask more fundamental questions. And then last, another component that interests me, I won't spend a lot of time on here, are temporal indicators. We have frequent exacerbators who often know that they only exacerbate in the fall, or they only exacerbate in the spring, or there's a real pattern, and yet we tend to list them often because of financial incentives as someone who has, I don't know, 3 asthma attacks in the last year. Or, we tend to do it on a longer temporal scale. And often these shorter temporal indicators may be more relevant to treatment and finding and eliminating that trigger. A big one I know was back to school, and it supports masking, was when the kids went back to school in the fall and everybody got that fall rhinovirus that just like spread everywhere. That was when we saw a ton. I mean, there was an asthma epidemic from that. And I can just imagine how well people have done with the asthma, with the masking with COVID, how incredible that could potentially be moving forward. So again, another potential precise intervention. So let's move up the ring to application and synthesis. And again, considering where we want to be precise with people with asthma and what kinds of unique interventions or precision. These are very common assessments in home inspections, but often the home inspection is done by one person and it's 40, 50, 60 items. And what clinician is even going to bother looking at that, right? So they might tell the patient, well, police yourself and then come back and let us know, um, what your trigger is, right? But it's kind of up to the patient to assess what that trigger is. So here we condensed all of these items into a quick to use 7-item scale. I have a picture of my little pet Rigby here because pets loaded on their own scale. And it's interesting if you look at this from a socioeconomic perspective, having a pet indoors can actually be an exposure of choice and privilege, where a lot of these other exposures tend to be housing quality. So it made sense that they loaded differently, but I would still assess for furry pets, furry and feathered pets indoors. So it's an inspection evidence of roach or mice, dust, mold, evidence of tobacco smoker. Now, these were non-smokers because we knew as soon as we've got smokers, it completely overwhelms everything when it comes to asthma. I mean, it is the orders of magnitude is the thing. It's the smoking gun. A properly vented bathroom fan, which may be again a proxy for mold and moisture. There's self-reports of pests and then access to a vacuum with HIPAA. So quick screening items. These tend to be done in home health, but we can now consider doing these in clinic or creating an interoperable measure to look at home environment. So this again just shows you that the frequency in this cohort of 187, how often it happened, and the most prevalent negative exposure was not having adequate ventilation in that bathroom. So that brings me back to mold and moisture again. We did detect a racial disparity. So this is a score that integrated 10 items. You saw the 7 plus the 8th with pets. It also integrated humidity and particulates, along with the patient's IgE. If they had pets in the home and they had a cat or a dog positive IgE, it matched and they got a point. If they had dust in the home and they had dust mite allergy, it matched and they got a point. So this was precision using biomarkers. What you're looking here in the blue is the highest quartile. So those with the highest risk score. And if you look, it seems pretty evenly distributed among the white and other race patients. Actually, more of them end up in the lowest risk quartile, but half of our Black patients are in the highest risk quartile. So the racial disparity is not only in the environment, it's in our bodies and what the IgE shows us. So to continue on, this is looking at application and synthesis and potentially new tools as nursing interventions. I'm going to back up here. So this is from a cohort in Erie County, which is where Buffalo, New York is. We had 51 adult women with asthma supported by the Heilbronn Center. We collected data with interview-assisted survey. They wore Fitbits and actigraphy devices. They self-administered spirometry twice daily. We had environmental sensors for temp and humidity in the home. We did a spot check for particulates. They kept a daily diary, as well as we did a medical record review. So we really pulled in all kinds of data in this particular cohort. Very low income, 63% below that poverty line. Median age was 40. 12% were multiracial, 47% were Black. So we were quite a diverse cohort there. 55% were obese, which is typical of working aged adult women with asthma. These were the patients that I would expect to see in the emergency department. So with the recruitment methods for this cohort, the average comorbidity was 17 additional active diagnoses, 17. And about a third of these patients were currently prescribed an antidepressant. So we know the self-management with asthma and depression, it can become, unfortunately, a very negative spiral of it's harder to self-manage because of depression, and the shortness of breath and the difficulty with daily activities can create a vicious cycle with depression. So the key to that was the new tools. Again, considering using a Fitbit as a quantified self, as an early response, because we know when people have complex asthma symptoms, they tend to normalize it. And so how do we kind of get the alert of this isn't normal, it's time to take action? So we did a predictive model of development using these wearable sensors, and sleep efficiency did help to predict that asthma-specific wakening. These were the other components that came up in the model that we developed, and relative humidity is in there once again. So the bedroom humidity, looking at that passive self-monitoring. So starting to see a theme in some of this work as to where we need to perhaps focus our preventative nursing interventions. This same cohort had a baseline survey where we asked them about what a healthcare provider had advised them to do. Again, this is a cross-sectional, so these are all items that were on the baseline survey, but we did find those who had asthma acute care utilization or unscheduled utilization for an asthma attack in the last year, fewer of them had or used a bathroom exhaust fan. So again, it may be a proxy for housing quality, but again, it brings us back to that potential for mold and moisture. So then COVID hit, as we're in the middle of a lot of this, and I know we've all done a bit of a pivot in our work. So I will circle back to some of the things that we've done with application and synthesis and implementation and adjustment in our COVID time. So a crucial role for the nurse intervention is patient education, and patient education on emergency department discharge is a huge area to create more precision, more relevant work, and really improve our nursing interventions. So this is a protocol that's now published in the Cochrane Systematic Review. The title's been modified just a little bit. It's social support. Now, and it is listed in the Queen's English and Cochrane Review. So behavioral has a different spelling if you look it up. But really, what we're looking at with COVID and what was an interesting and unfortunate disparity, including for those with asthma, is this household preparedness. If you had to shelter in place for 3 days, did you have what you needed to do that? And there were some shortages of albuterol at different times because it was being used in hospitals for acute care. So we're looking at what works, what does help people prepare. How should we be connected our teaching to this? My own work, I'm very interested, particularly in flood zones, because not only do we need to be prepared for the immediate emergency, but the cleanup and the mold and moisture after can have long-lasting effects on respiratory health and with asthma. Um, so again, we know that flooding worldwide accounts for 49% of all disaster deaths, 49% of all disaster events, 43% of all disaster deaths. It accounts for 68% of people affected by disaster pre-COVID worldwide, and of course is complicated by the pandemic. So weather and climate disasters are really increasing with frequency and with climate change, responsible for over 13,000 deaths, 1.75 trillion in additional costs, and of course, worsened morbidity over the last 40 years. In the older adults in the USA, 70% of them have 2 or more chronic conditions that they need to be prepared for to care in an emergency. So lots of opportunities to really look at our climate change intervention, our nursing interventions, really tied in with what we're doing in clinical care every day. Are our patient panels prepared? Are we including this in discharge education relevant to their chronic disease and their self-care? We're also on the policy level and crafting policy assessments and policy understanding linked to climate change, really looking at this idea of ozone as well as particulates. Right now in the Clean Air Act, and I'm working with the American Academy of Nursing expert panel with Lisa Thompson, with Dr. Thompson on this, there's a disaster loophole in our air quality policy. And that means if there's an exceptional event like a wildfire, the state can apply that doesn't count in part of the regulatory system. The United States is very unique in how many wildfires we have and how much they cost. And the truth is, we know a lot of them are human caused and preventable. We've simply not treated the air quality that results from them as if it was preventable. So some of the work we've done is to continue to look at both particulates and other criteria, air pollutants. Here you see ozone. The research question here was with the pandemic lockdown and less traffic and less industry, was there a change in our local ozone level? And using our time series, we actually did not detect a change. So that's what you see here. And it led us back to this policy of when are we exempting these exceptional events that we as nurses know land people in the hospital. We as nurses know impact health. And, why are we sort of washing our hands of this and not including it in what we consider regulated air quality? So that is a policy intervention we've been looking at. And on to practice. A lot of the work we've done is to inform policymakers through science advisory and to inform regulatory bodies. And as part of the pandemic, we saw nursing shortages based on surges in different geographic areas. So we dusted off some research that we had completed and submitted and was not accepted for publication. And it went to the bottom of the pile. So if any of you are sitting on a manuscript that was not accepted and you haven't gotten to it yet, here's some incentive that it becomes relevant again and you get excited about it again. So don't let it go too far. We looked at a few issues. One was looking at how many nurses there were across the United States that were licensed but not working, either retired or not working. That work is coming out in the Annals of Emergency Medicine. We have a substantive reserved workforce. And the question is, in a disaster or in a pandemic, are people ready and willing to return to work? Do we need to make workplace modifications both to train? But then the 12-hour hospital shift can be physically brutal. Are there telehealth options? Are there other support options for our reserve workforce capacity? Looking at burnout and psychosocial care of the nursing workforce, again, looking at this through the climate change and the disaster lens and the disaster preparedness lens, as well as an emergency nurse-initiated protocols for emergency triage is a crucial intervention. When I work in a place like New Mexico, when a patient comes in with chest pain, I could apply all kinds of protocol-based care to that patient long before the individual provider sees that patient. If in a disaster or because of relocation, I'm now working in a place like New York, the State Practice Act prohibits me from what I'm trained to do, what I know to do, and what's best evidence practice. So we really wanted to look at that, especially as we had the nursing workforce mobilized to different geographic areas with the pandemic and prepare for future disasters because we know with climate change, this is coming. So we continue to work on some of the policy, even related to nurse scope of practice across state lines. And we know that telehealth is environmentally friendly. So as much as we can shift delivery to telehealth, that may also cross state lines or make geographic boundaries irrelevant. And so what does that mean for state-based licensing compacts and scope of practice? So how are we doing with time? I'm going to try
Well,
to
we
just,
have 13 minutes left, and it might be nice to leave the last, 5 to 8 minutes for
yes,
questions.
good. I'm just going to briefly mention that the Environmental Protection Agency about every 5 years goes through each criteria air pollutant. It does this full systematic review. It comes out in almost a 2,000-page document. And then they do a policy assessment recommendation to decide if they're going to leave, for example, particulate matters or airborne lead, if they're going to leave it with the averaging and the form and the standard and the way it's measured, or if they're going to change that. And so our team, and I was working with a collaborator up in Health Canada on this, has looked into different health outcomes related to criteria air pollutants, and that work was included in the EPA's integrated science assessment. And again, as a policy intervention for how clean our air is outside, it did help to inform that work. So with that, we did look as nurses at a lot of this work uses the emergency department visit as the health outcome. And as an emergency nurse scientist, I need to be in this, right? I understand when it's misspecified or what's happening or how sick people are or what those confounding variables are that aren't being measured when we're looking at this in epidemiology. There was a rule that came out. They wanted to make all data sets used to inform regulatory science publicly available and start to really look at this in open science, which I support reproducible science, but if it's created because of the clinical encounter, we can't just make that publicly available, but it also shouldn't be excluded from regulatory science making. So through Annie and through the American Thoracic Society, several of us as science advisors provided testimony and public comment throughout the process, and it was remanded by the courts. This rule was vacated and remanded, and so what a tremendous impact that team did have. So a summary and the questions. Boldly ask those fundamental questions. As nurse scientists, as interdisciplinary scientists, you have earned your place to be there, and just always remember that CBC and an engineer creating that, right? You may have that outside thinking looking in that is the key to a huge discovery. Some of the precision interventions we talked about in development and looking to testing, especially as we look to make asthma more precise, are taking home screenings into the clinical record, looking at personalized trigger reduction. A lot of the science on overall trigger reduction shows a mixed outcome, but they're not the selection criteria is anyone with asthma, not specific people with specific triggers. Precision home modification by endotype and phenotype, again, with quite a focus on mold. mold and moisture and those kinds of whether one is colonized or when one is sensitized to common molds in the environment. We're using wearables for monitoring and self-monitoring, disaster telehealth for high-risk groups and household preparedness, and outdoor air quality policy. So I'm going to stop there and welcome your questions.
All right, thank you so much, Jessica. Does anybody have any questions? That was a great talk, super interesting and made me think a lot. So Liz, do you have a question?
Yes, can you hear me? Okay. Thank you, Dr. Castner. I was really interested in the ozone levels and the pre and post COVID. I think a lot of people will be interested in that as well. Do you have any thoughts on why they did not go down?
That is a wonderful question. I'm brimming with thoughts, and we'll have to figure out how much of these thoughts are useful. So ozone can be NOx limited, or it can be VOC limited, right? These different precursors combine to form ozone. And it really depends on what gets depleted in the local environment first as to what's creating ozone or not. So in this local area, there's been a lot of effort to reduce VOCs, a lot of concerted effort looking at industry that was misbehaving, looking at different activities. There still is industry. And what has not been looked at is the NOx levels and where is our nitrogen oxides? What's emitting that? What is it coming from? Part of that does naturally occur. So there isn't quite, VOCs do too, but, it may not be as obvious. And so to me, the answer is in these particular regions where the ozone did not decrease with the pandemic, it may not have been traffic related. So was there NOx? Was there home heating issues? Was there industry? Another really interesting component too is it's hard to take ozone by itself. And so as this ozone was doing the normal pattern, was our NOx going down? Was our VOC going down? Was there actually a victory in pulling down the precursors, just not enough yet that ozone changed? And we didn't get too loud about it because at very low levels, we don't want ozone action days. We don't want that health harming because it does direct damage to lung cells, and children exposed to ozone, their lungs don't develop to full capacity. That's just unacceptable. But what we don't know yet at very low levels is ozone may have some germicidal properties. If you walk into a lot of sports centers, there's the ozone cleaner, right? They advertise it to reduce odors. There used to be those air cleaners that were advertised to asthmatics that there's now warnings on because in cleaning the air, they would emit ozone. So your viruses and bacteria would go down and perhaps your pollens, but what it's doing, it's punching a hole in the cell wall of the germ. It may do the same thing to the cells of your lungs. But there's a lot of opportunity, I think, for us to really define at what point is it germicidal, at what point is it harmful, where is that sweet spot? Because right now there is no level at which we say ozone is so low it causes no health effects. We don't know that yet. So there's a lot of thoughts on that question. Did it answer what you were looking for?
Yes, ma'am. I always think about agriculture because that's where I am, and I always think of it. Looked like March and July were really the big ozone times, and that's really the big agriculture times too. So I didn't know if that had anything to do with it. I know they don't usually take a break during COVID. So
I was also thinking that, the creation of ozone requires sunlight. And so, you'd have to, like you said, the precursors, the factor of the photochemical reaction, it requires sunlight. So maybe in the winter months, it tends to be lower because there's less sunlight throughout the day. But I was also going to comment on what Jessica said about the ozone formation machines. And I was just looking at the, that with the now we're not really post-pandemic, but the trying to get kids back into schools and the money that's been given to schools to clean the indoor air, and billions of dollars are being spent, and these ionizers or ozone generators have actually been marketed to schools, and they can cause more harm than good if you have them inside the school generating a lot of ozone. In fact, there was in New Jersey, I think they spent $7 million on these ozone machines for schools to clean the air of the virus, which has, the EPA says this is not a good thing to do. So we don't have just ozone outdoors now, we also have to contend with ozone indoors.
Yeah.
Any other question?
Hi, Sarah Valentine. I have some background noise. There's a lawnmower outside, so we may get noise out of the blue. But actually, I had two things. The first is I just wanted to reflect on this when you were speaking of the EPA standards, the healthy air standards. And I understand that they were revised relatively recently and that Annie actually had some voice in that, but that they essentially stayed at the same limits. Of course, it's a new policy environment now. I'm also thinking about D et al.'s paper from 2017, which looked at particulate matter for the entire Medicare cohort and showed that there was, with a 10 microgram increase per cubic meter of particulate matter, there were substantial increases in all-cause mortality. But I think what's really compelling, that's very compelling, and also very compelling racial disparities, but also that relationship was at a linear level that just kept going right below the cutoff of safe air limits. So it just seems to me like that's a real call, just that, evidence on its own, but also other evidence to really kind of start advocating again around the clean air limits, because I think that those standards, become such a point of reference that the true impact on human health is, it's hard to hold up and advocate for that.
Agree with you. Absolutely. And that was an incredibly powerful study. And in many ways, that's what started to motivate that conversation about, well, with wildfire smoke and those particulates, that really affects, when I worked out west, that really impacted patients with respiratory disease and patients with cardiac disease. And with how widespread and how profound that is, it's time for us to start considering that as some form of, it's regulatable.
Thanks. And then just my follow-up on that, and it's not, maybe you'll have an answer, maybe it is a question, but also maybe just a thought to put out there is I'm very interested in how hospitals, particularly nonprofit hospitals that are beholden to community benefit, so the possibilities for those hospitals to really respond to air pollution as a determinant of health. And so I'm wondering what you've seen, if, even with your research findings that really show mold, for example, is a really powerful predictor and influence on asthma exacerbations. I'm wondering to what extent, and in Erie County and other places, you've seen hospitals start to kind of get to that granular level of working on environmental determinants in a way that's affecting the health of their populations.
What an incredible question, and thank you. And Beth Shank, who's a member of Annie, is going to be a go-to expert on what hospitals are doing themselves. I have worked with several, it's often started by physician groups who contract with hospitals, very concerned about the incineration and the waste stream. And so that tends to be, especially if it's not going to cost the hospital a whole lot, if they can make greener alternatives without it affecting the bottom line, that's a huge opportunity there. So Erie County, it contains particularly with Buffalo in the inner city, one of the highest rates of intergenerational poverty and truly one of the poorest cities in the nation. And so it's a struggle to look at long-term prevention as a priority. And now I know a lot of hospital systems are in that, when it's just, we got to make it to next month's spreadsheet in, not in the red. However, to frame that, and there's some wonderful resources that we can follow up with, and again, Beth's a great resource on, well, what about disaster preparedness? What about starting to look at this in that climate change lens, and how are your disasters changing? You know, here we're going to have more precipitation, so perhaps more flooding, more blizzards. But then what does that mean for if you shut down surgery? Or, you know, you start to sort of speak the language of the C-suite as to what are your sources of revenue, and is there a climate impact on really hurting that? And if so, let's start there. That is a great question. And a lot of times, right, the whole public health component, the whole prevention component, we know if we invested more in that, we'd save more lives. But there is a disconnect with how acute care is funded, right?
You know, I realized I sent you my personal link for this meeting, and I now have a meeting with my another colleague, so we'll have to end it here. But Jessica, thank you so much, and we'll post this on YouTube and look forward to seeing you all next month. I wanted to say that Liz Mizell is going to join me as the co-chair, and Luz is rotating off, but Luz, I hope you will show up to our meetings. Okay.
Wonderful.
Okay,
Thank you.
thank you. If y'all could sign off, then then I'll just stay on for Wei Sang. Thanks.
Do you want to stop the recording?
I am doing that now. Thank you.